Welcome. In this session, we are going to talk about the surgical approaches to the various orbital spaces and a little bit on the post-operative care and complications of orbital surgery. There are 5 surgical spaces in the orbit. We have the subperiosteal space between the bony orbital wall and its lining periosteum called the periorbiter, the extraconal space between the periorbiter and the cone of the recti muscles, the intraconal space within the cone of the recti muscles, the subtenon space between the tenon's capsule and the globe, and the subarachnoid space between the optic nerve and sheath. Orbitotomy approaches can be divided into superior, inferior, medial, and lateral. Superior orbitotomy can be through a transcutaneous route, a transconjunctival route, or a vertical lid split incision. The transcutaneous superior orbitotomy approach is usually done through an incision along the superior eyelid skin crease, which provides an excellent cosmesis as compared to an incision along the superior orbital rim. This incision allows access to the subperiosteal space, the extraconal space, and the medial aspect of the intraconal space. To access the subperiosteal space, the incision through the superior eyelid skin is carried through the orbicularis oculi muscle, and then dissection is carried superiorly till the superior orbital rim is reached. Here an horizontal incision is made along the arcus marginalis, which is the attachment of the orbital septum to the periorbita along the superior orbital rim. Then the periorbita is separated from the orbital roof to access the subperiosteal space along the orbital roof. To access the extraconal space, after reaching the preseptal space, dissection is carried posteriorly through the orbital septum to reach the extraconal space. Access to the medial aspect of the intraconal space is done after entering the extraconal space, after which dissection is carried medial to the levator palpebrae superioris muscle and then posteriorly through the intermuscular septum between the superior and medial rectus muscle. So to reach the intraconal space, the muscles are not transected. In the transconjunctival superior orbitotomy approach, a horizontal incision is made along the superior conjunctival fornix, and this incision can give access to the superomedial portion of the extraconal space, the intraconal space, and the subtenon space. However, care must be taken to avoid damage to the LPS and the lacrimal ductules while incising the conjunctival fornix. In the vertical eyelid splitting superior orbitotomy approach, a vertical full thickness eyelid incision is made, and this gives a wide access to superomedial intraconal space. But at the end of the surgery, a vertical eyelid splitting approach needs accurate closure of the tarsal plate and the levator palpebrae superioris muscle to prevent ptosis, lid retraction, and notching of the eyelid margin. In all superior approaches, every attempt should be made to avoid damage to the levator palpebrae superioris, the superior oblique and the trochlea, the lacrimal gland, and blood vessels and nerves near the superior orbital rim. Inferior orbitotomy approaches can be transcutaneous or transconjunctival. For a transcutaneous inferior orbitotomy approach, a subciliary incision just inferior to the lower eyelid margin gives a better cosmesis and less eyelid retraction as compared to an incision along the lower eyelid skin crease or the lower orbital rim. This incision gives access to the subperiosteal space, the extraconal space, and the intraconal space. To reach the subperiosteal space along the orbital floor, the subciliary incision is carried through the orbicularis oculi muscle, and the dissection then proceeds inferiorly between the orbicularis oculi and the lower lid retractors up to the lower orbital rim, and then an incision is made along the arcus marginalis, where the orbital septum joins the periorbita at the lower orbital rim, and then the periorbita along the lower orbital floor is lifted to reach the subperiosteal space along the orbital floor. The extraconal space along the inferior orbit can be accessed by dissecting posteriorly through the orbital septum and carrying the dissection inferiorly. For accessing the intraconal space after reaching the extraconal space, further dissection is carried posteriorly through the intermuscular septum between the inferior rectus and the lateral rectus muscles. So to reach the intraconal space, the muscles are not transected. This diagram is taken from the session on the anatomy of the eyelid and has been zoomed here to highlight this region. The transconjunctival inferior orbitotomy approach is favored over the transcutaneous inferior orbitotomy approach. And herein a horizontal incision is placed in the conjunctiva either at the lower border of the inferior tarsus or in the lower conjunctival fornix. For wider access, additional lateral canthotomy and inferior cantholysis is also done. And when a cutting cautery is used to make this incision, thermal damage to the tarsus or the conjunctiva must be avoided. This incision gives access to the extraconal space when this incision is carried through the lower lid retractors. The subperiosteal space can also be accessed from the transconjunctival incision by incising the periorbita at the arcus marginalis after reaching the extraconal space. The intraconal space is accessed through the transconjunctival incision after reaching the extraconal space and then dissecting posteriorly through the intermuscular septum between the inferior and the lateral rectus muscle. And with an incision through the bulbar conjunctiva and Tenon's capsule, the subtenon space can be entered. And the subtenon space approach can also give access to the inferior aspect of the intraconal space by retracting the inferior rectus muscle away from the globe. For all inferior approaches, care must be taken to avoid damage to the inferior rectus, the inferior oblique, and the infraorbital vessels and nerves exiting the orbit near the lower orbital rim. A medial orbitotomy approach can be transcutaneous, retrocarancular, and transconjunctival. In the transcutaneous medial orbitotomy approach, a frontoethmoidal incision is made medial to the insertion of the medial canthal tendon, and this is typically used to access the medial subperiosteal space and anterior portion of the medial extraconal space. By deflecting the medial canthal tendon along with its insertion on the periorbita, the lacrimal apparatus, including the lacrimal sac, the canaliculi, and the nasolacrimal duct, can be protected from the dissection. In the retrocarancular medial orbitotomy approach, the incision is made posterior to the caruncle, and this gives a better cosmesis as compared to a frontoethmoidal transcutaneous incision. The retrocarancular approach also allows access to the subperiosteal and the extraconal spaces of the medial orbit and is suitable for tumors, fractures, and decompression of the medial orbit. And the retrocarancular approach can be combined with an inferior transconjunctival incision for accessing both the medial and the inferior portions of the orbit. During the retrocarancular approach, care must be taken to prevent damage to the lacrimal apparatus by remaining posterior to the lacrimal apparatus. In the transconjunctival medial orbitotomy approach, incision on the bulbar conjunctiva gives entry into the extraconal space, and this incision can also be used for medial orbital tumors, fractures, and decompression of the medial orbital wall. Further detachment of the medial rectus muscle from the globe gives access to the intraconal space. An additional lateral orbitotomy with removal of the lateral orbital wall allows lateral displacement of the globe and a wider and more posterior access to the medial intraconal space. In all medial approaches, care must be taken to avoid damage to the medial canthal tendon, the lacrimal sac, and the canaliculi, the trochlea along with the superior oblique muscle and tendon, the inferior oblique muscle, and nerves and vessels along the medial aspect of the superior orbital rim. The lateral orbitotomy approach is used to access the lateral intraconal space and also the lacrimal gland fossa. And the incision for lateral orbitotomy extends up to the skin over the zygomatic arch from either of the upper eyelid crease or a lateral canthotomy incision, and an incision starting just beneath the upper eyebrow along the superior orbital rim is now obsolete because of scar formation. After the incision, the temporalis muscle lying along this area and the periorbiter reflected to expose the lateral orbital rim. And for deeper access to the lateral orbit, a portion of the bone from the lateral orbital rim is removed, and this is also called marginotomy. At the end of surgery, the removed portion of the lateral orbital rim is replaced back to its original position by sutures through pre-drilled tunnels or by microplating systems. And as children have shallow orbits, they do not usually require bone removal from the lateral orbital rim for adequate access to the lateral intraconal space. The lateral intraconal space is then accessed through the periorbita and the intermuscular septum above or below the lateral rectus muscle. Approaches to posterior orbit and the orbital apex includes a transnasal endoscopic approach when it is usually combined with an orbitotomy, or a transcranial approach followed by removal of the orbital roof. Orbital decompression surgery is primarily indicated in thyroid ophthalmopathy patients having compressive optic neuropathy, and two types of decompression can be done, either bone decompression or fat decompression, and they can also be combined. In bone decompression, portions of lateral, medial and inferior walls are removed. So this shows the right orbit with the regions of the lateral orbit, the medial orbit or the inferior orbit, which can be removed during orbital decompression, and any one or a combination can be used as required. In balanced decompression, portions of both lateral and medial orbital wall are removed so as to minimize globe displacement. However, it is important to remember that removal of superior orbital wall for orbital decompression has to be avoided so that we do not enter the intracranial space. Fat decompression involves removal of retrobulbar fat and not removal of pre-aponeurotic fat only. Postoperative care following orbital surgery includes adequate hemostasis and placement of an external drain to the deep orbit before closure of the orbital incision, and measures are taken to reduce orbital edema such as head elevation, ice packs over lower lids and systemic steroids. And what is very important is close monitoring of vision, because there are chances of orbital compartment syndrome from occurring due to hemorrhage after orbital surgery, which needs prompt intervention to save vision. We have discussed orbital compartment syndrome and its management in the previous session on orbital trauma. And prophylactic systemic antibiotics are often given. Complications of orbital surgery include loss of vision, a very important post-operative complication following orbital surgery to be aware of. And this can happen from traction of the optic nerve, contusion of the optic nerve, or compression of the optic nerve from orbital compartment syndrome, when it is usually associated with severe pain. Following orbital surgery, ptosis can also occur, as well as globe displacement, injury to extraocular muscles and their motor nerves, injury to ciliary ganglion and postganglionic fibers arising from the ciliary ganglion, causing pupil and accommodation abnormalities, injury to sensory nerves from the ophthalmic and the maxillary division of the trigeminal nerve, dry eye and neurotrophic keratopathy, injury to the globe causing VH and retinal detachment, orbital cellulitis and cerebrospinal fluid leakage. Thank you for listening.